Hello students, we'll start with the next topic on amoebicidal drugs. So the learning objectives for today's session include to know and study about Amabiasis and the life cycle of amoeba, and second, to classify and to study the pharmacology of amoebicidal drugs. So first let's discuss about amoebic disease and the life cycle of amoeba. Now, amoeba, it's a disease which is caused by a protozoa called as Entamoeba histolytica. Now, this organism, Entamoeba histolytica, it invades the gastrointestinal mucosa and also some other internal organs like the liver or pulmonary areas by one of the forms of the trophozoite, one of the forms of the protozoa known as trophozoite. So, this is widespread in many parts of the world, and in some of the tropical areas you will get to know that 50% of the people in some of the countries have been found to have this parasite in their stool. So it's a very common infection. Millions of people, they have Entamoeba histolytica in their intestines but with no clinical symptoms. Now, these asymptomatic carriers of amoeba may spread the infection to other people who are not resistant to the infection. So in addition, the carriers who have never had intestinal symptoms may develop extra-intestinal amoebiasis, which is usually marked by amoebic liver abscess. Thus, amoebiasis in man represents in the form of symptoms as first asymptomatic intestinal infection, second mild to moderate intestinal infection, third severe intestinal infection, that is dysentery, fourth amoebic liver abscess, and fifth amoeboma or extra-intestinal infection. So these are various grades of severity of the diseases, starting with asymptomatic infection wherein there is no symptoms at all, and with mild to moderate and to severe intestinal infection, and followed by affecting the other internal organs like the liver or the other extra-intestinal organs. Now coming to the life cycle of Entamoeba histolytica, this has two main life cycle stages. One is a cystic stage in which the organism can live for long periods both outside the body and within the human intestine. And second is a trophozoite form. This is a vegetative stage wherein the organism is motile and under suitable environmental conditions in the intestine, it tries to invade the intestinal mucosa, forming multiple ulcers. Now, these trophozoites basically they release a substance which digests the mucosal cells, and finally they find their way through the mesenteric veins to be carried to the liver by portal circulation, resulting in amoebic hepatitis or liver abscess. So you can see in this picture that a man gets infected first with an infective cyst which is contaminated with food or water. So this cyst enters the colon, and under favorable conditions the organism exists in the intestine by asexual reproduction in the colon and leads to a trophozoite form. So here you can also see that each cyst here it develops into 8 trophozoites, usually in the ileocecal region of the intestine, and a colony is established in the cecum which extends toward the colon. Now the trophozoite is the trophozoite form of the organism will pass on to the stool and it is not infective. So the trophozoite can either encyst itself and form an infective cyst in the normal stool. The Entamoeba histolytica can also invade the mucosal cells and have its direct entry into the portal vein and have its access into the liver, forming liver abscess. So in this picture, you can see the entire life cycle of Entamoeba histolytica, how it travels through the colon, and once it comes out from the fecus, it can either be in the cyst form or the trophozoite form. The trophozoite form becomes ineffective, or not infective. But the cyst form is a asymptomatic carrier. It is taken up by the oral fecal route by the humans, and again it enters a life cycle. So just to summarize, Amabiasis is an infectious disease caused by a free living amoebic parasite called Entamoeba histolytica. It is a protozoal disease. Organism infects the bowel and causes gastroenteritis. Mode of transmission is by the orophycal route, means infection occurs by ingestion of the cysts through contaminated food or water. Excistation occurs in the ileum of the small intestine. The trophozoite multiplies by binary fission in the large intestine, and most remain in the lumen of the intestine. However, some may invade the intestinal mucosa, enter the bloodstream, and develop in extraintestinal sites. The cyst formation is triggered by the dehydration of the gut contents in asymptomatic carriers. It is more common in countries with poor sanitation. The incubation period may last from days to weeks before symptoms actually appear. And the disease spreads through food and drinks that are contaminated by Entamoeba histolytica. So this is what we have seen about amoeba and its life cycle. Very interesting. Now let's go to the drugs. So we have seen that how trophocytes, they form an important intermediate for asymptomatic carriers in the form of cyst, or they are multiplied in the intestinal lumen and they cause ulceration of the invade the intestinal cells and form intestinal ulcers, or leads to amoebic dysentery, or how they cause extra intestinal amoebiasis as well, infecting the other organs, mostly the liver. So in this picture, you get to see that how the trophocytes, or they also multiply by binary fission within the lumen of the intestine, and under favorable conditions like during dehydration also they get converted into cyst. So they can pass into the fecus, or else these trophozoites can also cause further damage on the intestinal walls leading to ulcers, and they can find their way through the portal vein into the liver and form liver abscess. So you get to see that the trophozoite is the main portion in the life cycle, which once inhibited will take care of the cyst as well as the trophozoite multiplication as well. So we need to focus on the trophozoite. The trophozoite needs to be killed first. So accordingly, where depending upon the site of action, drugs are classified as anti-amoebic drugs in two main classes. One is a tissue amoebicides which will be having effects on both intestinal as well as extraintestinal amoebiasis. And second is a luminal amoebicides. That means the trophozoites which are getting multiplied, or the cyst which is being there in the lumen, which is ready to pass by the stools, those are taken care by the drugs. So first class is tissue amoebicides, the drugs which are effective in both intestinal as well as extraintestinal amoebiasis are first nitroimidazole, which is the very common anti-amoebic drug which is prescribed, metronidazole, which is also called as flagyl, tinidazole or ornidazole, and alkaloids, which are not much under prescription to be seen because of their very serious side effects, emitting, dihydroemitting and all. And for extraintestinal amoebiasis, you have a special drug called chloroquine, because this has an ability to get stored in the liver. Luminal amoebicides, you have got again three classes. Amides like Diloxanide Pyruvate or nitazoxanide, 8-hydroxyquinolines, iodoquinol and cleoquinol, and antibiotics to support the action of antiamoebic drugs like tetracyclines or erythromycins or parabomycins. So let us see individual drugs one by one. Well, the first drug under tissue amoebicidal category is nitroimidazole, mebendazole, which is also called as flagyl, ornidazole, propionidazole, tinidazole like drugs. Metronidazole, the mode of action of this drug is it enters the cell by passive diffusion. It inhibits nucleic acid synthesis by disrupting the DNA of the microbial cells. So here the amoeba cells are exposed once they are exposed to metronidazole, it inhibits the nucleic acid synthesis. So nucleic acid synthesis, once it is inhibited, so there is no chances of multiplication of these tropocytes. Adverse effects of these drugs are minimal, but some of them are characteristic. Like nausea and diarrhea are very common. Side effects also include unpleasant taste or furry tongue, glossitis, stomatitis, anorexia or abdominal cramps, and darkening in the color of urine. Drug interaction talks that when it is taken with alcoholic beverages, it produces disulfiram type of reaction. You understand this reaction disulfiram when alcohol is taken and you have this enzyme alcohol dehydrogenase and aldehyde dehydrogenase. So you have under the influence of these enzymes acetaldehyde being formed in the body and characteristic symptoms appear which is not taken up by the patients, and therefore that helps in keeping the drug away from the alcohol away from the patient. So here disulfiram actually inhibits the enzymes. That is the role of disulfiram. So acetaldehyde levels will increase. So when they are combined with alcoholic beverages, metronidazole probably acts like disulfiram and increases the level of causes accumulation of acetaldehyde in the body, and that causes very unpleasant symptoms in the patient like abdominal distress, nausea, vomiting, and headache. This drug also has a potential for depressing the bone marrow. Superinfections with Candida albicans may develop, and this drug is used for both intestinal as well as extra-intestinal sites, and currently the most preferred drug for amoebic infection. May it be amoebic dysentery or liver abscess or extra-intestinal amoebiasis. The usual dose is 750 milligram orally 3 times daily for 5 to 10 days. So relatively a safer drug and very effective for tissue amoebicidal diseases. Well, the next class of drug coming under tissue amoebicide are the alkaloids. The very famous Emitting, the alkaloid which was obtained from the roots of Syphilis ipecacuanha, was once upon a time a very powerful drug to be used as an antiamoebic drug. Although these days very seldom they are used, very rarely they are used because of the availability of more better drugs like metronidazole. Emitting has a direct lethal action on Entamoeba histolytica. At very high doses, it is also active against the cysts. So this is a very special feature that even the trophozoite as well as the cyst form can be taken care by Emitting. Emitting inhibits the protein synthesis by interfering with the attachment of tRNA to the ribosomes of the protozoa. So this acts as against how we have seen about metronidazole. It interferes with the DNA synthesis. Here, it also acts in a similar way by interfering with the attachment of tRNA to the ribosomes. So protein synthesis is inhibited. It causes damage to liver, kidney, skeletal, and cardiac muscle. So this is not a very good acceptable sign for Emitting. The primary adverse effect of Emitting is on the cardiac tissue because it has a tendency to get concentrated in the cardiac tissue. Cardiac conduction and contraction are depressed by prolonged use of Emitting. Susceptible patients, they will immediately develop ventricular arrhythmia. So atrial and ventricular arrhythmias are very common. In ECG, you will get to see the T wave flattening and inversion, widening of the PR and the QRS intervals also. It also partially blocks transmission at the skeletal neuromuscular junction, causing muscle weakness, stiffness of the muscles, especially of the neck and the extremities. And since it has a cumulative action, dosage should not exceed 60 milligram per day for 10 days. So beyond that, if it is given, then cardiac adverse effects are likely to happen. So since this drug is having a very adverse effect, very bad adverse effect on the cardiac. This is never the first choice of drug for amoebic therapy. The next drug, dihydroemitting, is structural analog of emitting. It is having action similar to that of emitting. It is a structural modification of emitting. It retains semi-basidial activity of the emitting, but it is a less toxic drug as compared to emitting. And this drug is shown to concentrate more in the liver and less in the heart compared to emitting. That is one good feature with dihydroemitting. And its dose in severe intestinal amoebiasis is 1 milligram per kg intramuscularly or subcutaneously for 3 to 5 days. There is one more drug called Emitting Bismuth iodide, which is a mixture of 25% of Emitting and 25% of Bismuth. So it is orally administered compound which releases Emitting slowly in the bowel. So like a sustained release drug. So under alkaloids, we have seen about Emitting, dihydroemitting and Emitting Bismuth iodide. So the next class of drug coming under tissue amoebicides is 4-aminoquinolines or chloroquine. Now, chloroquine is a very useful in drug for treating hepatic as well as pulmonary amoebic infections in conjunction with emitting or dihydroemitting. Chloroquine has got a quinoline nucleus, and this is the nucleus which is responsible for the action or the efficacy of the drug. The efficacy of the drug primarily depends upon this integrity of this quinoline nucleus. It has got no effect on the luminal form of the disease. It's a pure tissue amoebicidal drug, and since it has got a tendency to concentrate in the liver, it is more effective in liver abscess or amoebic liver disease. It is rapidly and completely absorbed from the upper bowel and is concentrated in the liver. And longer periods of administration increases the frequency of gastrointestinal disturbances. So virtually no side effects or unwanted effects with chloroquine. The next drug is halogenated hydroquinolones or iodoquinol and cleoquinol like drugs, which are drugs used for the treatment of luminal amoebicides, primarily acting in the bowel lumen. So it exerts a direct action, that is amoebicidal action, against the trophozoites and cysts of Entamoeba histolytica in the intestine. It is ineffective in extraintestinal amoebiasis. Iodoquinol is particularly useful in the treatment of asymptomatic cyst carriers, passers, and people with mild to moderate intestinal infections. They are also used in superficial fungal infections, these drugs. One important characteristic neurological toxic action, which was found to be peculiar with geographical distribution, was SMON, that is subacute myeloptic neuropathy, which was first observed in Japan. So people in Japan who were consuming this new drug, iodoquinol and cleoquinol, developed this syndrome called subacute myeloptic neuropathy, in which there is bilateral sensory disturbance, muscle weakness in the legs, pyramidal signs, and blurred vision and blindness. So therefore, the use of these drugs are restricted. Next drug, amides or diloxanide pyruvate. This drug is directly amoebicidal again and primarily acts on the trophozoite forms of the parasite and therefore used in asymptomatic and mildly symptomatic cyst passers. It is less effective in acute amoebic dysentery, free from side effects. Nausea, abdominal cramps, dry mouth, pruritus, urticaria, albuminuria are rarely seen. Another class of drugs, antibiotics like tetracycline, erythromycin, and paromomycin, also help in eradicating intestinal microflora, which are essential for the proliferation of trophozoites of Entamoeba histolytica. So intestinal microflora is also one of the factors which favors the growth or proliferation of trophozoites of Entamoeba histolytica. By eradicating this intestinal microflora, we are aware of this antibiotics. One of the side effects is the gastrointestinal microflora levels are decreased, and because of which other superinfections also develop. So, taking advantage of these effect of antibiotics, that see, antibiotics cannot be given alone. It has to be used as an adjunct with other antimycocidal drugs, more particularly ones which are used against luminal amebicides, that is halogenated hydroquinolones and amides. So we have seen about drugs which are effective against tissue luminocytes like emitting, chloroquine, ones which are effective against both tissue and luminal amebicides like nitroimidazoles, and the ones which are effective only in luminal amebicides like iodoquinol and cleoquinol like drugs or amide type of drug.